Dr. Mansour is known for his special love of physical diagnosis. I am not the only one that will nag you to do a good physical exam. He is also the author of one of my favorite books. Did you know I was going to stump your book? Frameworks of Internal Medicine. He didn't know I was going to do that. Um, it's really a remarkable book that helps to solidify core concepts into understandable flow charts. I'm happy to share it with you guys if you want to take a look at it. But Dr. Mansour is certainly someone that we always enjoy having, and he's going to go over valvular heart disease with you. So just one reminder, while he is going to share some audio files with you, I'm not going to have any on the exam, so don't panic. Spend your time just sort of thinking about what's happening when, why does it sound like this, what's going on, for sort of general understanding purposes. You're going to have to listen to a lot of hearts to start being able to sort this out. So this is just our beginning. So thank you, Dr. Mansour.
Well, thank you, Pat. I really appreciate that kind introduction, and I'm glad the feelings are mutual because Pat is one of my favorite people, and I always love it when she joins us on the wards. Yeah, we'll get started with that. So this talk is called Valvular Heart Disease. Here are the objectives. We're going to review the basic cardiac cycle. I cannot stress enough how important it is when you're approaching any part of the cardiac exam to know where you are in the cycle and understanding what events are happening within the heart during systole and during diastole, what valves are open, what valves are closed. We'll identify some key historical and physical findings in valvular heart disease. We'll talk about etiologies and management. We'll probably spend a little less time talking about management, more time talking about making the diagnosis and diagnostic process. That's probably the most important thing in medicine in general, and especially for these boards exams, because really, if you can identify the diagnosis, if you can make the diagnosis, at the very least, you can narrow down your answer choices. So I think it's really important to be able to identify what valve lesion they're referring to in the question stem. And of course, the last objective here is in bold because that's really obviously this stuff is important, but it's done in a way, this talk was created in a way to really focus on your boards exam and try to help you pass your boards exam. So this is a kind of a framework for approaching murmurs in general in adults. And it kind of breaks down by, in terms of cardiac cycle, again, how it's so important to know where you are. That extra sound I'm hearing, that murmur, is it in systole or diastole? That totally dichotomizes your differential diagnosis. So it's really important. And then from there, understanding the shape of the murmur and then figuring out, is it on the left side of the heart or the right side of the heart? So this is kind of a nice sort of framework for thinking about these different valve lesions and where they fit kind of in this framework. So we're going to focus on a handful of these lesions, and we're going to spend some time focusing on those: aortic stenosis, hypertrophic obstructive cardiomyopathy, or HOCM, mitral regurgitation, a subtype of regurg called mitral valve prolapse, tricuspid regurgitation, aortic regurgitation, and mitral stenosis. So before we get to the individual murmurs and lesions, a little bit about cardiac anatomy. So there are 4 valves. Mitral valve and tricuspid valve, I typically pair those up together, and the aortic and pulmonic valves pair those up together. Why? Because those valves should be open at the same time and should be closed at the same time. And generally, the same lesion, whether it's mitral regurge or mitral stenosis, the same thing for the tricuspid side, is going to cause a similar sound. So mitral regurge and tricuspid regurge are going to sound similar. Aortic stenosis, pulmonic stenosis, they're going to sound similar. So those valves are kind of paired up together. The mitral valve separates the left atrium and the left ventricle. The tricuspid valve separates the right atrium and right ventricle. The aortic valve separates the left ventricle and aorta, and the pulmonic valve separates the right ventricle and pulmonary artery. Really important to understand kind of the anatomy and have that in your mind when we're approaching murmurs. So the cardiac cycle. So what happens in systole? Well, here the ventricles are contracting to eject blood into the aorta and the pulmonary artery. The LV is responsible for pumping blood into the aorta. The RV is responsible for pumping blood into the pulmonary trunk. Again, during systole, the aortic and pulmonic valves should be open. The gates should be wide open to allow blood to flow through them, whereas the mitral and tricuspid valves should be closed because you don't want blood going backwards into the atria. So those valves should be closed during systole. In diastole, now the exact opposite is happening. Now the ventricles aren't contracting, they're relaxing to receive blood from the atria. And so obviously the tricuspid and mitral valves should be open at that point to allow blood to go from the atria to the ventricles. The aortic and pulmonic valves, now the opposite is true compared to systole. Those are no longer open, they should be closed to prevent blood from leaking backwards from the aorta or the pulmonary circuit back into the LV and RV, respectively. The beginning of systole is marked by closure of the mitral and tricuspid valves, and the closure of those valves is associated with S1, okay, the lub part of Lub Dub. The beginning of diastole is marked by closure of the aortic and pulmonic valves. That's associated with S2, the dub part, so Lub Dub. So you'll notice here, so we've got S1, we have S2, and in between them is systole, and then, in between S2 and S1 is diastole. Really important to kind of have an understanding of that. There are two basic types of valve lesions. There's stenosis and regurgitation. So stenotic lesions, stenosis affects the valve when it should be open. The gate should be open to allow blood to flow through, but there's something causing partially blocking that gate. And then when the blood passes through, it's going to create turbulence. And that turbulence causes the murmur. So stenosis occurs when the valve should be open. Regurgitation occurs when the valve should be closed. The doors of the gate should be closed, but there's something causing the gate to be the doors to be ajar. And that's causing leakage, and that creates turbulence as well in a murmur. So every valve can be stenotic or regurgitant, and therefore every valve, whether it's the aortic valve or the pulmonic valve or the tricuspid valve or the mitral valve, can cause a murmur in systole or diastole, because all the valves should be open at some point and should be closed at some point. And if stenosis is occurring when there should be open, there's going to be a murmur in that cycle, part of the cycle. If it's the aortic valve, that's going to be during systole. Regurgitation now occurs when the valve should be closed. So aortic regurgitation, the aortic valve should be closed during diastole. So regurgitation during diastole is going to cause a murmur during diastole. So aortic regurge is a diastolic murmur. Now, as I just mentioned, each of the four valves can be either stenotic or regurgitant, so therefore it can cause a murmur in systole or diastole. The aortic and pulmonic valves are open in systole, so stenosis there is going to cause a murmur. They are closed in diastole, so regurgitation there is going to cause a murmur. The mitral and tricuspid valves, the opposite is true. They're opened in diastole, so mitral stenosis is going to cause a diastolic murmur, whereas they're closed in systole, so mitral regurgitation is going to cause a murmur in systole. Now, there are 5 key physical features of murmurs that we report when we think about murmurs. We want to know the timing. Again, is it systolic or diastolic? We want to know the shape. Is it crescendo, decrescendo, or is it holosystolic or plateau shape? Where do we best hear it? What's the radiation pattern? Where does it radiate to? Maneuvers. These 5 things are key, and they love to test on these things. And they're buzzwords. They will give you the answer by telling you about the timing, about the shape of the murmur, the location, etc. So let's talk about timing first. So again, we want to know, is it systolic or diastolic? Test questions will often provide this info. Or they might say something like a murmur is heard between S1 and S2, and you would know that's a systolic murmur. This allows for immediate dichotomization of the differential diagnosis, as we talked about. So if you know if it's systolic or diastolic, it narrows your differential considerably. The shape of the murmur is also helpful, and there's 4 basic shapes. Okay, there's 2 in systole and 2 in diastole. So the 2 systolic shapes would be crescendo, decrescendo. It gets louder and then quieter. This is known as a diamond-shaped murmur. So it sounds like this. Holosystolic is otherwise known as plateau shape, and that's flat all the way across. So it sounds like this. Versus okay. Now, on the diastolic side, you have two flavors of murmurs there as well. It's going to be decrescendo, so it's going to sound like this. Starts off loud, gets quiet. Reverse cone on its side.
Dr. Mansour,
Yeah.
we can't actually hear you making these sounds or too quiet. Are you able to get closer to the mic when you're doing?
Yeah. Here, let's try. It could be a frequency thing where I don't know, this microphone just might not pick up. Okay, so you have crescendo, decrescendo, which is can you hear that? Holosystolic is can you hear that? Okay, I mean, it's probably a frequency thing. It's just not picking up that frequency. And let me see if I can try. It's like this. Versus okay, cool. Now decrescendo starts off loud and gets quiet, so it's whereas decrescendo crescendo is like a it gets louder at the end. Okay. Now, again, test questions will often give this information. They'll tell you the shape. And again, this will allow for further narrowing of your differential. Again, the second sort of arm of this framework here is the shape. So if you're in the systolic side and you know it's crescendo, decrescendo, well, you can eliminate all of these possibilities. You can focus on these, okay? Now, next is location. So you all are familiar with the kind of the mnemonic Al Pacino, the man, I think, APTM. Oh, let me pull up the chat because I see people are. Yeah, and by the way, yeah, feel free to use the chat. You can unmute yourselves to ask questions anytime. And then also, when we get to the recordings, it's best if you can listen with headphones or with good computer speakers. If you try to listen, if you're listening through your phone or something like that, it won't work out very well. Matthew, what's your question?
I was just going to ask, when someone talks about like a musical murmur or like a gallop, are they talking about the shape and the time, or are those other types of features?
The musical quality is more a frequency thing. And then the second part, you mentioned gallops.
Yeah.
And yeah, so a gallop is a transient sound. It's not going to be a sound. So when I listen to the heart, I think about transient sounds. That's like S1 and S2, a sound that's got, quick. It's gone just as it starts. It's like a clicking or a popping sound. Whereas sounds with duration, they have duration to them, as the name implies, and that's more like a murmur. So it's gonna have a duration to it. So don't worry so much about gallops for the moment. Let's focus on murmurs. And we'll get to kind of the musical quality later on. There's a certain type of murmur that kind of has a musical quality at times. Now, in terms of location, you've got Al Pacino, the man, or aortic, pulmonic, tricuspid, mitral. General rule of thumb. You should also think about base versus apex. Okay, so up towards the sternal border is the base of the heart. Towards the apex area, that's the apex. Towards the mitral area. Okay, so that's location. Now, you need to be aware of 4 basic locations. Okay, the aortic area is the second intercostal space, right upper sternal border. Pulmonic area is just the opposite on the other side of the sternal border, so it's second intercostal left upper sternal border. Tricuspid is here, the lower left sternal border, and mitral area is the apex, kind of near the nipple. And again, test questions will provide you with the location because it's very important. It'll help you narrow things down. Radiation pattern, there's a couple that you should take to the bank. If they tell you that the murmur radiates to the carotids or the clavicle, that's aortic stenosis. Done. If they tell you that the murmur radiates to the axilla, that is mitral regurgitation. Done. Okay, now maneuvers. Now, maneuvers tend to trip people up. Okay, before we get to them, a couple other quick buzzwords. If they tell you left lateral decubitus position, think mitral stenosis. If the patient's leaning forward, think aortic regurgitation. Okay. Now, to get to maneuvers, these tend to confuse people a lot. And there's a little bit of a lag here, so I'm trying to advance slides. Give me 1 second. Okay, now all maneuvers boil down to a couple important principles that you have to understand. All they do, whether it's leg raise or Valsalva or standing to squatting or squatting to standing, all these things do are manipulate blood volume across a lesion, okay? And most often, if you increase blood volume across a valve lesion, the murmur that is created is going to get louder. There are 2 exceptions, which we'll talk about. Okay, so think of it this way. If I've got my thumb over the nozzle of a hose, and we've got the hose turned up halfway, well, as the water goes past my thumb, it's going to create turbulence, and you're going to hear it you're going to hear, shh. Okay, now if somebody goes and turns up the hose all the way, my thumb has not moved, but now what was shh is going to be shh. It's going to get, much louder. Because blood volume, if you increase blood volume across a lesion, it's going to create more turbulence. Now, there are 2 exceptions to this. Okay, we'll get to those in a moment. So just keep in mind that most murmurs are going to increase in intensity with increased blood volume and decrease in intensity with decreased blood volume. Just for clarification, you can only do a maneuver for mitral or aortic issues. No maneuvers will elicit a pulmonary or tricuspid pathology. No, not quite true, Morgan. We're going to get to this. Christina asks, by radiation, does that mean we can hear the murmur in those regions as well? Yes, exactly. You can hear it as well, as a primary spot, or just almost as well. Okay. Now, there are 3 basic ways to manipulate blood volume. You can alter blood return. You can increase blood return to the right side of the heart. You can increase blood return to the left side of the heart. And you can alter afterload. Okay, and these are going to manipulate blood volume across the lesion. I'll tell you how. So let's talk about the first way, which is altering blood return to the right side of the heart. This is inspiration. Okay, when we take a breath in, we decrease our intrathoracic pressure, and that's going to bring blood flow from the rest of the body back towards the right side of the heart. Okay, and it's isolating it to the right side of the heart. You guys, I know what you're thinking. You're thinking, well, if you're going to increase blood return to the right side of the heart, well, you must be increasing blood return to the left because the blood is pumping from the right to the left. That is true, but not in that moment. And the reason is because inspiration also causes vasodilation of the pulmonary vessels, leading to actually decreased blood return to the left side of the heart. So when the patient's breathing in, you're increasing blood flow to the right and you're decreasing blood flow to the left. So a lesion on the right side of the heart is going to get louder with inspiration because you're increasing blood flow across that lesion. So any murmur on the right side of the heart is going to increase with inspiration. That's called Carvio all right? Now, it's a really key maneuver. If anything, if it's on the left, it's going to get quieter because you're decreasing blood flow to the left, and also you're increasing air in the lungs between the scope and the heart. So most murmurs are going to get quieter with inspiration on the left. But if it gets louder, it's on the right. Okay, so that's maneuver number 1, inspiration, and that's going to isolate. That's going to increase turbulence on the right side. So it's going to tell you it's a right-sided murmur. That is completely isolated to the right side. Inspiration has nothing to do with the left. So that's inspiration. All right. So the next, and by the way, that'll help you in the last tier of the framework, differentiate whether you're on the left side or the right side of the heart. Okay. So next up.
I actually have a quick question.
Yeah.
If we're instructing patients on how to do this, especially as learners, and we're having to have them inhale all the time, are we just having them inhale and then hold their breath as long as they can and then just keep repeating that?
It's a great question. So what I usually do is I have them just tidal breathe first and see if I can appreciate it getting louder when they're breathing in. But then what I also do to bring it out is sometimes I'll have them breathe all the way out and hold it. And sometimes patients get confused by this. When they hear hold your breath, they take this big breath in and hold it. Well, I like to get a baseline sense of their heart sounds with them breathing all the way out first. It empties the lungs, and it's going to make all heart sounds kind of easier to appreciate, at least at first, at baseline. So I have them breathe all the way out, and it's just a nice maneuver to do anyway, because sometimes when their breathing is noisy and it's hard to appreciate the heart sounds. So having them breathe out and hold it will allow you just to focus on the heart. Then I get a good sense of what their baseline is. Now I ask them to breathe in slowly. Sometimes I use my hand. I tell them beforehand, okay, when I do this with my hand, breathe in. So they start to breathe in, and I can hear that murmur get louder when they breathe in or not. Okay.
Thank you.
Yeah, absolutely. So now we're going to talk about altering blood return to the left side of the heart. So now these are things like leg raise, going from standing to squatting, because when you go from standing to squatting, you flex your calf muscles and everything else to mobilize the blood back to the heart. Now, all murmurs are going to increase with these maneuvers, with two exceptions. That's mitral valve prolapse and HOCM. And we're going to talk about, you can just memorize that for your tests. Those are going to do the opposite. It's always better to think about why that happens. So we're going to talk about the why in a moment. Now, when you decrease blood volume to the heart, that's squatting to standing, or Valsalva. When they Valsalva, they increase their intrathoracic pressure, and that's going to prevent blood from returning to the heart. All murmurs are going to decrease in intensity with those two exceptions, mitral valve prolapse and HOCM. Now, why would that happen? Why do HOCM and MVP behave in this way? Well, let's think about HOCM first. Now, imagine my right hand here is the LV, okay? And the septum is between the LV and the RV on this side, all right? So normally it's a nice thin septum. And see near my fingertips here, this is the outflow tract. So the LV squeezes blood through to the aorta. Now, it's nice and wide open, that outflow tract. Now, if I have HOCM and my septum hypertrophies and thickens up, look what happens to that outflow tract. It gets compromised, right? Now, if I do something to maybe I have the patient go from standing to squatting, which is going to increase blood return to the left. Now, all of a sudden, my LV gets bigger. The cavity gets bigger because it's filling with more blood. What happens to that outflow tract? It opens right up. So it's going to be a quieter murmur, and it's going to occur later in systole when that LV reaches that critical volume when it's contracting, to now create an outflow tract that becomes compromised. Does that make sense? It's going to do the opposite. So volume is going to expand that LV out. It's going to open up that outflow tract. All right. Now, MVP, also imagine my right hand is the LV. My left hand is the valve. The back of my hand here is the valve leaflets, and one of my fingers that are connecting the valve leaflets to the LV. Those are the chordae tendineae, okay? Now, mitral valve prolapse is usually a disease of patients with Marfan syndrome or other connective tissue diseases like Ehlers-Danlos, or they had an MI or something where those chordae tendineae become lax. All right, they're not tight and taut anymore. Normally they're attached to the LV and they pull the valve down shut. If I have lax chordae tendineae and that LV, it contracts down, these become lax, and what's going to happen to that valve? It's going to parachute up into the left atrium, and that's going to cause regurgitation around it. So if I expand out my LV, what's it going to do? It's going to pull those chordae tendineae down taut. It's going to pull that down, that valve down shut. Okay, so when the LV is contracting now, it's going to take a while before it reaches that critical volume where the chordae tendineae become lax and parachute up, and then you get the murmur. So it's actually a bit of a misconception when they say the murmur gets quieter with increased blood volume. It's actually that it occurs later. It's just, the intensity doesn't really change. It just occurs later in systole. Now, the opposite is true. If I have them Valsalva and all of a sudden that LV is starting off at a really small volume to begin with, well, it's not going to take much before those chordae tendineae become lax and parachute up, and you get the murmur. So it occurs sooner in systole. Does that make sense? The test writers, though, are frankly also under this misconception. So they're going to tell you the murmur gets louder with Valsalva, but it's actually that it occurs earlier in systole. All right. Hopefully that makes sense. Now that's why those two behave in a different way. Now, the last maneuver to talk about is afterload. And again, all this is doing is manipulating blood volume, like we talked about. So the way you increase afterload is you can have the patient do hand grip. So they make a fist and squeeze their hands tight, or you can blow up blood pressure cuffs on both arms and pump them up. That's going to increase afterload. So what do you think that's going to do? Well, in somebody that has aortic regurgitation, for example, where the aortic pressure, so you've got the gradient between the aorta and the left ventricle. Normally it starts off, kind of high because you just finished systole and the aorta has all the blood in it. It's got a high pressure and the LV is empty. So it's got this gradient. Well, if all of a sudden you increase afterload, you're going to increase the aortic gradient even higher. So what's that going to do? It's going to drive more blood backwards into the LV, so the murmur gets louder. It's going to increase blood volume across that lesion. Same is true for MR. So when you have mitral regurgitation, when the LV squeezes, there's two options for the blood. It can go out the aorta normally, or it can go backwards into the left atrium. If you increase the afterload, well, the blood's going to go the path of lesser resistance, right? Just like Ohm's law. So it's going to go, more of it's going to go backwards. So you're going to increase the blood volume across that mitral valve, and you're going to increase the MR murmur. All right. So that's maneuvers. And some of these things can take a little bit of time to kind of conceptualize. Go back over this recording and just remember the principles. You're just manipulating blood volume across a lesion, whether you're standing and squatting, squatting to standing, Valsalva, whatever it is. And most lesions are going to get quieter with more blood volume, with those two exceptions. Other key physical features. So for aortic stenosis, if they tell you about the peripheral pulse, pulsus parvis et tardus, that's a weak and delayed peripheral pulse. That's a key buzzword there. You know that you're dealing with aortic stenosis on the test. And as I mentioned, if you can figure out what lesion you're dealing with, even if it's a management question, you've at least narrowed down your possibilities and your answer choices. And most often they're not going to ask you about management. Most often it's just getting the diagnosis is key. Aortic regurge also affects the peripheral pulses. You're going to get things like Corrigan's pulse, which is a bounding pulse in the neck, Waterhammer pulse, bounding pulse in the radial artery. Quincke's pulse is a pulsation in the nail bed. Tricuspid regurgitation, you're going to get Lancisi sign or CV fusion in the neck. Mitral stenosis, the murmur is going to be described as rumbling in quality, and it's going to be associated with an opening snap. If you see those things, take it to the bank that they're talking to you about mitral stenosis. Okay, now let's go over some individual lesions. And we're going to start with aortic stenosis, which is very, very common. Okay, the history, it's most often going to be an older patient, and they just get calcific degeneration. It may be a young patient with a bicuspid aortic valve that degenerates sooner in life. So keep that in mind. They present with three cardinal symptoms: angina, syncope, and heart failure, or dyspnea from heart failure. On exam, they're going to have a crescendo, decrescendo systolic murmur at the right upper sternal border that radiates to the neck or the clavicle. Okay, you might also have a soft S2, you might also have an S4 gallop, and then pulsus parvis et tardus. And I bolded those because, again, those are commonly tested, commonly included in test questions, and you can take it to the bank. On EKG, they might also have LVH or left axis deviation. And this is what aortic stenosis sounds like. So this would be a good time to put your headphones on and take a listen. And you can see it. So this is a crescendo, decrescendo, systolic murmur. It's between S1 and S2. Okay, it's crescendo, decrescendo. It's right up here at the right upper sternal border. Here's an example of an earlier peaking systolic murmur. Okay, so it peaks and then there's a longer pause and then S2. Okay, so in terms of echocardiogram, there's criteria for determining whether aortic stenosis is severe or not. And, basically you want to kind of remember these numbers over here. So the jet velocity and the mean gradient, just think 4 and 40. It's kind of easy to remember. It used to be that the valve area was part of the criteria, but it's no longer. But less than 1 centimeter generally implies severe disease. Now, in terms of management, If you have severe aortic stenosis, it all depends on whether the patient's symptomatic or not. If they're not symptomatic, you just want to do yearly echoes to follow that valve lesion. If they have moderate AS, you want to follow it 1 to 2 years, and for mild AS, it's 3 to 5 years. In terms of those are asymptomatic patients. Now, once they're symptomatic and have developed symptoms, then you're talking about valve replacement. Okay, and you also want to keep in mind that surgeons don't like to crack open the chest more than once, so they'll often do angiography to see if this person has CABG, so they'll do both at the same time. Okay, but it's a surgical issue, severe symptomatic AS, and they have to have that valve replaced. So let's move on to hypertrophic obstructive cardiomyopathy, which is actually not a valve lesion. It's not a valve lesion. It's just thickening of that is obstruction of that outflow tract just below the valve. Now, if the test question mentions a young athlete, you're done. They're going to talk about HOCM. That answer is HOCM. They typically present with dyspnea, chest pain, syncope, similar to aortic stenosis, because it's the same type. It's a very similar mechanism. Family history of sudden death, think HOCM, because these patients also get conduction abnormalities because of ischemia to the conduction system. They can have VFib, VTAC, and they can die. That's often how they do die. And so if they have a family history of sudden death, think HOCM. The exam is going to be similar to aortic stenosis in that you're going to get this decrescendo murmur, but it will not radiate to the neck. And instead of having weak and delayed pulses, in aortic stenosis, sometimes it's really hard to find the pulses. In HOCM, the pulse is actually brisk. And as I mentioned, they love to test maneuvers. The intensity of this murmur will decrease with increased blood flow. It's going to do the exact opposite of what you would expect. And the intensity will increase with reduced blood flow. Okay, you might also get LVH and left axis deviation and some prominent Q waves on EKG. Here's what it sounds like. It's going to sound similar to AS. And watch this. You can even hear my voice in the sound when I tell the patient, okay, bear down. And you can see the intensity, and you'll hear the intensity of the murmur get much louder with Valsalva, which would otherwise make all other murmurs quieter. Okay, let's listen. Management for HOCM, you only really manage it if they're symptomatic. You kind of want to improve diastolic filling, so we try to use beta blockers or calcium channel blockers to try to slow down filling to allow more fillings. Remember, it's going to expand that outflow tract out if you have more LV filling. You want to avoid medications like diuretics and things that are going to compromise LV filling. Yeah, it looks like somebody is trying to ask a question. Matthew.
Yeah, I just have a quick question. So you said to be able to differentiate the HOCM from the aortic stenosis was, one, the history can be an identifier, and two, the maneuver is going to help you identify that it's HOCM versus aortic stenosis?
Yep.
Those are the two main differentiators?
Those are the two main things, exactly. And radiation pattern, AS is going to radiate to the neck, HOCM will not, but the demographics are going to be big. So if it's a young, especially a young athlete or something like that, think HOCM. If it's an older patient, think aortic stenosis. Now, there is the exception with a bicuspid aortic valve, but they would have to tell you that. If they tell you that there's a bicuspid aortic valve, then think, okay, this person could have developed aortic stenosis early, so they might be in their 40s or 50s.
Okay, thank you.
Yeah. Yep, exactly. Sports physical, it's often picked up during that time. Exactly. Now, if patients are having symptoms, really it's a surgical issue, and they can do these things called, they can ablate the tissue with alcohol. Alcohol is toxic to the myocytes, so they infuse some alcohol there, and it kind of melts some myocytes away, and it opens up that outflow tract. Let's touch on mitral regurge next. So, the history here, there's primary and secondary mitral valve issues. Primary issues when you just have degenerative changes for whatever reason, that's hard to predict. But on a test question, if they tell you about infective endocarditis, so endocarditis causes regurgitant lesions, okay? So it's going to cause mitral regurge, it's going to cause aortic regurge, tricuspid regurge, et cetera, and so forth. So infective endocarditis could be a clue. Rheumatic heart disease could be a clue that's most often associated with mitral stenosis, but they can get just breakdown of the valve and develop mitral regurge as well. And then his secondary causes would be from ischemia or dilated cardiomyopathy. When the ventricle dilates out, it's going to dilate that annular ring of the valve as well. And now the doors of the gate can't touch each other. So you've got this hole in the middle, right? That's called functional MR. And that happens as a result of dilated cardiomyopathy. On exam, they'll tell you that there's a holosystolic murmur over the apex with radiation to the axilla. Radiation to the axilla is bolded because if you see that, take it to the bank that it's MR that they're getting at. You might also hear an S3 gallop. The intensity is going to increase with increased afterload. All right. Here's what MR sounds like. It's a plateau-shaped, flat-shaped murmur extending all through systole. So here's S1, here's S2. You're not really going to hear that. You're just going to hear a flat-shaped murmur. Here it is in the axilla. Okay, so the treatment for mitral regurge, there's pretty minimal medical management. You try to reduce afterload if you can to promote forward flow, but then really it comes down to surgical management like most of these valve conditions. So repair, clip, replacement, a bit too nuanced for this talk and for your test. They're not going to test you on those three, but just be aware that there are different options for treatment. And that's really the surgical team. And there's actually a complex valve team at OHSU. That's how specialized this is. So don't worry so much, but really focus on making the diagnosis. Mitral valve prolapse is a subtype of MR that we talked about already. And it usually occurs in patients with connective tissue disease, Marfan syndrome. They say that it's the most common form of valvular heart disease. That's definitely a myth. On exam, you're going to hear this mid-systolic click. So if you see mid-systolic click, that is MVP. And then it's going to be followed by this kind of plateau-shaped murmur. It's late in systole. And the intensity, again, is going to decrease with increased blood volume. It's going to do the opposite of what you'd expect. Okay. So the keys here are the mid-systolic click and the late nature of the systolic murmur. And this is what it sounds like. So what you're going to hear, this loud sound is S1. Then you're going to hear kind of a pause, kind of silence. And then you're going to hear this murmur and then S2. And then a longer pause. Okay, so it's a late systolic murmur. There's no click here. The first time I ever heard mitral valve prolapse, I thought I was hearing a diastolic murmur because your brain gets fooled into thinking that because there's this S1 and then this pause and then the murmur. So your brain just thinks, oh, that's diastole, but it's not. It's actually late systole. So let's play it. You guys appreciate that? It's kind of, you hear S1, don't, and then shh, don't, shh, don't, shh. TR, most often can be associated with endocarditis from IV drug use. You can also get the same functional TR if the RV is dilated out like you can with the mitral valve. On exam, you're going to hear this holosystolic murmur at the left lower sternal border. It's going to be associated with the CV fusion or Lancisi sign in the neck. And it's going to increase in intensity with inspiration. And here's what TR sounds like. Do you guys notice that it's getting louder at times? Like it's louder here, then it's quiet, then it's louder, then it's quiet, then it's louder. This is tidal breathing. This is a patient just breathing in and out. You can hear it get louder. And then here it is with we're purposefully asking them to breathe in. This is Lancisi's sign, by the way. This is CV fusion. This is a venous waveform in the neck. Look at that thing. Because when the RV squeezes, all this blood is going backwards into the RA because of the severe tricuspid regurgitation and into the neck. So you see it with each ventricular beat. You see this wave going to the neck. Okay, management. Again, pretty limited role, kind of for both medical management and surgery. They rarely perform tricuspid valve surgeries. It's not always so obvious. No, that's a good question, Christina. It's not always so obvious. But if you get good enough, you'll be able to really appreciate it. It's a diagnosis you can make right at the bedside just by walking in the room. And you can look at their neck and say, this person has tricuspid regurgitation. Aortic regurgitation is next. So here you're going to have, again, a patient with degenerative changes who's prone for that. So somebody with bicuspid aortic valve, endocarditis, rheumatic heart disease, connective tissue disorders like Marfan's, aortic dissection, syphilis. If you see any of those things in the question stem, think aortic regurgitation. And again, the aortic valve should be closed during diastole. So it's going to be a diastolic murmur. It's going to be decrescendo in shape because that gradient is going to be greatest in the very beginning. And once that blood starts flowing backwards in the LV, the gradient starts to equalize. So it starts off loud and gets quiet. And then you're going to have a ton of peripheral findings like Quincke's pulse. Okay, so here's what aortic regurg sounds like. It's a decrescendo. Look at that sideways cone. Decrescendo diastolic murmur. So Matthew, good question. So basically they mentioned history of syphilis or active syphilis or either one. Think aortic, aortic valve, because you can get aortitis from syphilis. And that was, before penicillin and all that stuff. That's how people dissected a lot and developed severe AR, aortic regurg, is because of syphilis affecting the aorta. And it causes dilation of the aorta, and that ring is going to dilate out. Yeah. So good question. So I should have harped on that a little bit more. So remember, we talked about rules of thumb. Al Pacino, the man. Those are just rules of thumb, and there are some exceptions to that. So aortic regurg is one of those exceptions where, you actually hear it over Erb's point, which is the middle of the left sternal border. And that's just because the direction of the jet, the aortic jet, is kind of going in that direction. So you just hear it best there. Okay. So not really over the aortic area like you do with aortic stenosis. Yeah. Here's Quincke's pulse. So can you see the nail bed pulsating there? It's blinking. It's going from kind of red and white. I don't know if you can appreciate that. You guys see that? Yeah. So really neat finding that can really help make a diagnosis. You want to reduce afterload as much as possible medically. But again, it comes down to surgical management, especially symptomatic severe AR. They're going to need that valve replaced. Okay, let's talk about mitral stenosis as the last individual lesion here. So the history, almost always related to rheumatic heart disease. It's going to be patients from developing countries, Romania, Mexico, etc. And they often present with AFib and embolic events. Keep that in mind. They may also present with hemoptysis because of the hemodynamic changes that mitral stenosis creates. You get kind of rupture of the pulmonary capillaries. On exam, they're gonna tell you there's a low pitch rumbling, decrescendo, crescendo, diastolic murmur heard over the apex in the lateral decubitus position. You're also going to hear a loud S1, and there will be an opening snap. They might not tell you it's an opening snap. They'll tell you it's an extra sound right after S2. Okay. And, you know, why is there this pre-systolic accentuation? Well, what happens at the very end of passive ventricular filling? The atrium is going to contract to try to squeeze that last bit of blood into the ventricle. And when it contracts, it's contracting against a stenotic valve, which is going to create more turbulence and a louder murmur. So it gets louder right before S1. And this is what it sounds like. A lot going on in this recording. The loudest sound here is S1, as you'd expect. Systole is totally quiet. Then you have S2, and then an opening snap, and then a rumbling diastolic murmur that gets louder right before S1. So it sounds like this. If I start with the murmur, whoop, but up, whoop, but up, whoop, but up, whoop, but up. So take a listen. A lot going on in this one. Here's a loud S1. Okay, management. So for AFib, they have to be anticoagulated. Very important. They're really high risk for embolic events, stroke and stuff. For asymptomatic patients, you know, for just the valve disease, you watch it. For symptomatic patients, they basically need that valve replaced or treated in some way. All right, for the last 10 minutes or so, I put together some practice questions. So these are vignettes from an actual cardiology, you know, board review book, and we'll try to identify the valve lesion based on the description. I haven't changed anything. We'll try to recognize key buzzwords, and maybe you guys can use the chat box or unmute yourselves. So what's the valve lesion here? Cardiovascular exam reveals a point of maximal impulse that is laterally displaced. There's a grade 3 out of 6 holosystolic murmur at the apex with radiation to the axilla, and S3 is present. Does anybody know what valve lesion they're getting at here? Yeah, and what type of mitral lesion? Is this, yeah, mitral regurge, exactly. And the keys here, holosystolic, apex, radiation to the axilla, and the S3. Perfect. Next one, cardiac exam reveals an S4 at the apex and a grade 3 out of 6 mid-systolic murmur over the base that accentuates with Valsalva maneuver. So straight out of a board's review test. So what are they getting at there? Key features here being, yeah, exactly. So it's S4, it's kind of later in systole. It accentuates with Valsalva. Valsalva is going to decrease blood flow to the heart. There's only 2 lesions that are going to get louder with that. It's going to be HOCM or MVP. And, you know, the S4 gallop is a clue that you're dealing with. And they would have told you that there was a mid-systolic click as well. So nice job there. Okay, next one. Okay, a grade 4 out of 6 early systolic murmur that increases with inspiration, best heard in the second left intercostal space without radiation to the carotid arteries. So key here, yeah, so increases with inspiration. We know we're dealing with a right-sided lesion, and it's over the pulmonic area, and it's an early systolic murmur. So so we know that the pulmonic valve is probably involved, and it should be open during systole. So it's pulmonic stenosis. Nicely done. Cardiac exam demonstrates an irregular rhythm, a loud S1, normal S2, and an extra cardiac sound heard just after S2 near the apex, and a low-pitched diastolic murmur is heard following the extra sound. This is word for word from the board review book. So what valve lesion is present here? Yeah, this is mitral stenosis. Again, AFib, key. Loud S1, key. Extra sound, that's your opening snap. A low-pitched diastolic murmur, so bingo. All right, there's a bit of a lag here, so. Okay, mitral stenosis. Okay, next one. On physical exam, blood pressure is 150/40. The carotid upstroke is brisk and collapses quickly. There's a grade 2 out of 6 early systolic murmur noted at the second right intercostal space. A grade 3 out of 6 high-pitched decrescendo diastolic murmur is noted over Erb's point. There's evidence of nail bed pulsation. This is AR. Why is there a systolic murmur? There often is. Look at these clues. So look at that wide pulse pressure. That's a big clue of aortic regurge. If you see a blood pressure like that, think aortic regurge. Again, the brisk carotid upstroke. There's a systolic murmur and aortic regurge because you think of it as a flow murmur. With each beat, you have this big bolus of blood going backwards in the LV. So each squeeze, you have this huge stroke volume. So you get this functional flow murmur. Even though there's no stenosis, you have all this blood flow going through a kind of a normal gait, but it creates turbulence. So that's AR. Good job. Next one, cardiac exam reveals a sustained apical impulse, normal S1, and a single soft S2. An S4 is present. There's a grade 3 out of 6 early systolic, late peaking murmur that is heard best at the right upper sternal border and radiates to the left carotid artery. Carotid pulses are delayed. What are we dealing with here? Those are your clues and your buzzwords. There's only one thing this could be, especially with radiation to the carotid artery, and then the delayed pulses. Yeah, this is aortic stenosis, exactly. Grade 3 out of 6 systolic apical murmur is heard that radiates toward the left axilla. Moving from a squatting position to a standing position increases murmur intensity. What are we dealing with here? So going from squatting to standing, you're going to decrease blood volume to the heart. So there's only two things that will get louder with that. Exactly. This is mitral valve prolapse. Yep. I think we only have a few more. Cardiac exam reveals a loud S1, normal S2, and an opening snap. You can pretty much stop there. There is a regular rhythm with a grade 2 out of 6 holosystolic murmur at the cardiac apex radiating to the axilla, and a low-pitched 3 out of 6 mid-diastolic murmur following the opening snap that accentuates pre-systole. So actually there's two lesions here. What two lesions are we dealing with? Mitral valve regurge is one of them, and mitral stenosis is the other. Exactly. Cardiac exam reveals a grade 2 out of 6 holosystolic murmur at the left lower sternal border that augments with inspiration. Evaluation of the jugular venous pressure reveals a single large pulsation. There are track marks present in the antecubital region of the arms. So what are we dealing with here? We've got a holosystolic murmur, left lower sternal border. It increases with inspiration. So we know we're on the right side. There's a single pulsation in the neck. There are track marks. This is tricuspid regurge from endocarditis from IV drug use. Exactly. That's it. You guys did great. Thank you for having me. I hope that was helpful. Again, focus on making the diagnosis of whatever valve lesion based on those descriptions and those keywords. And once you do that, you're going to be able to get the answer right, or at the very least, narrow it down. And that's the talk. Happy to stick around. Looks like there's 5 minutes or so. Happy to stick around for questions, comments, discussion, whatever you guys want.
Dr. Mansour, I have a quick question.
Sure.
So one of the things we have to pay attention to is like preventative measures for these different types of valvular diseases. I understand there's like modifiable risk factors like diet change and weight loss and other things like that. Is there any other like surgical preventative measures you can do? I know with like mitral stenosis, you can try to regulate the AFib that could exacerbate that problem, but is there any other kind of techniques?
Yeah, I mean, it really depends on the valve lesion that you're talking about and what's causing it. I mean, honestly, there's really not much you can do to prevent a lot of these things. You know, there's not much you can do to prevent age-related aortic stenosis, for example. There's just not much you can do about that. You can try to prevent, you know, aortic regurge related to endocarditis, you know, by not doing drugs, for example, or, you know, giving yourself the risk factor for endocarditis. Or, you know, if you have dilated cardiomyopathy and you're going to get functional mitral regurge from that, yeah, I mean, if you address the dilated cardiomyopathy and you treat that and it gets better, you might prevent that mitral regurge from happening. But you know, somebody with Marfan syndrome, there's not much they can do to prevent their mitral valve prolapse. You know, so it really depends on the condition and the driving factor there. But there's really, and even then, there's really not a lot you can do. You know, even surgically, really. So it's just a matter of, you know, what's causing it and trying to modify some things. Yeah, certainly if, you know, aortic aneurysms, the risk factors there are male, it's not modifiable, hypertension, age. So some of those, yeah, if you can control their blood pressure, you might prevent their aorta from dilating out and causing that functional aortic regurge. So it really depends on what kind of lesion we're talking about and what the cause is, but there are some limited things that you can do in certain cases.
Okay, thank you.
Yeah. So anemia causes murmurs. Yeah, absolutely. So this is it's a flow murmur. So it's just like aortic regurge. So when you have an increased bolus of, just like what we talked about with maneuvers, if you have an increased bolus of blood moving across, usually we're talking about lesions here, but in this case, it's a normal valve, the normal aortic valve, it becomes functionally stenotic in a way, because now you have so much more blood volume going across that normal valve. You know, it's just too much blood for that valve. Even though the valve is normal, it creates turbulence because there's too much blood. So things like anemia, fever, pregnancy, liver disease, sepsis, aortic regurge, all those things cause increased blood volume. You know, there's the compensation from anemia, the 3 cardinal compensatory things that happen your body does when you become anemic. One of them is you increase blood volume. So you become hyperkinetic, and you know, that just is going to create more blood across a normal aortic valve, and it's going to cause a murmur. Does that make sense? It's a flow murmur.
Can you one more time list those other conditions that will cause an increased blood volume?
Yep. So fever, you know, or sepsis, fever, liver disease, pregnancy, you know, aortic regurgitation is going to cause that. Anything that causes high output physiology. You guys heard of high output heart failure from things like wet beriberi or thiamine deficiency? That'll do it. Paget's disease will do it. Thyrotoxicosis. So thyroid disease, you know, it is going to cause hyperkinesis of the heart, and it's going to cause an increased blood volume going across the valve. Yeah.
Okay, thank you very much.
Yeah. Of course.
I kind of have a tangent question. I know you weren't talking about a certain type of murmur. I think it was the Flint murmur, where it's kind of at the like apex of the heart.
Mm-hmm.
Is it an actual valvular issue that's causing that murmur, or is it something else in the heart that's causing that sound?
Yeah, good question. So an Austin Flint murmur is something that is associated with aortic regurgitation. And so what happened, so basically what happens is it'd be really helpful if you guys pulled up an image of the mitral valve and its proximity to the aortic valve. So when you have this regurgitant bolus of blood going from the aorta down into the LV, that regurgitant bolus of blood, so the mitral valve should be open at that time, right? Because that's during diastole. So blood's flowing from the left atrium to the left ventricle normally. And the valve leaflets are wide open like this. Well, the aortic, that jet that's coming down from the aorta is gonna push this valve shut. So it's gonna like push it shut during diastole when it should be open, because that aortic jet is coming down and pushing it shut. So you get a functional mitral stenosis as a result of that. So you hear also a mitral stenosis murmur in aortic regurgitation. So that's another kind of a higher level thing. And if that's confusing you guys, don't worry about it. Probably will not show up on your tests. But that's a good question. And that's and if you guys go, by the way, if you go to this website, we have a website called pdx.com. You'll see all the examples that we looked at today, plus hundreds more. And yeah, exactly. Yeah, thanks for the link, Milo. So yeah, you can see in here examples of Austin Flint murmurs and everything else. Not just murmurs. You'll hear gallops. You'll hear opening snaps. You'll hear pericardial knocks. You'll see neck vein stuff, all that. So, well, we are at the hour, so I'm sure you all have something else to go to now. Like I said, I'm happy to stick around for more questions if there's time, or you can always email me as well.
Dr. Monster, quick question.
Yeah.
The links that you left us at the end, the physical diagnosis PDX, is that where we can go and listen to the recordings of these murmurs?
Yes. Yeah. Go to pdx.com. I put the link in there, or physicaldiagnosispdx.com. Same thing. That's our website, and all of these things are on there.
Okay.
Yeah,
Thank you.
yeah. You are very welcome. I'm glad it was helpful. All right. Thank you guys. You're going to kill your test. Don't worry. You're going to kill it. All right. Bye-bye.